Good evening, everybody. My name is Dr. David Giuliani, and tonight we're going to talk a little bit about some of the restorative solutions in the modern digital age. That's going to include some scan and send demonstrations and how you can increase the technology in your office to a scanning solution rather than conventional impressions. I'm here tonight with Miss Angela Severance, and she's going to spend some time on that demo tonight. Angela, if you want to introduce yourself a little bit, we'll get moving forward.
Sounds good. Thanks, Dave. Hi, everyone. Yep, Angela Severance. I'm the Customer Success Manager for Ivoclar's Chairside Digital Solutions. Background of dental assistant. I've been doing CAD/CAM for over 15 years now. I'm really excited for this opportunity to share about what digital dentistry can do for your practice.
Excellent. Well, thank you, Angela. What we're going to do tonight is we're going to talk a little bit about the differences between traditional or conventional dentistry and some of the modern dentistry we can do, and the benefits it really presents and provides not only your patients, but you, your staff, and your practice. So if we look at traditional dentistry and some of the things that it takes to continue restorative practice, we have all of these steps. And in fact, there are, after the exam, up to 6 steps that it takes to get any type of conventional or what we would consider an analog crown, meaning gold or porcelain fused to metal. What this means is there are 6 additional steps where things can actually become distorted, become warped in the impression, or the wax up can go wrong as far as the patient, the way they're biting, and we can have occlusal issues. We want to minimize these, and that's one of the benefits that some of today's modern scanners have done for us. And we're going to specifically talk tonight about the Viva Scan from Ivoclar. And this scanner is going to be simple and easy to use. Once Angela gets that, you're going to see how nice and easy it is. And we're not going to ask you to do anything different in your dentistry. You are going to prep a crown exactly like you prepare that crown every day. The only thing we're going to ask you to change is the minute you go ahead and put your handpiece down, instead of picking up the impression gun in your lower left there, we're going to ask you to pick up a scanner. And what that scanner does for us, it really minimizes all of these steps. We're going to ask you to go ahead and just scan the prep and the opposing arch, and we're going to show you all of that a little bit easier and how easy that is and quick and efficient. What that's going to do for you is it's going to give you a model like you see there right in the center. The great thing about today's scanning, especially with Viva Scan, it gives you the option to really view, not only for you, but for your patients, the entire arch in color. So what it shows you, you can see the existing dentition as well as existing restorations in whatever form they are. So what this gives your practice is the ability to not only teach and educate as well as restore the teeth, but it gives you a kind of a future for your patients to understand their mouth and what everything looks like existing there, so you can plan for future treatment when you're moving forward and sequence things in a way that patients understand because it's right there in the screen for them. When it comes to the differences between traditional and analog impressions, we've all been in this moment, correct? And these are the moments we want to avoid, not only us in our practice, but also our patients.
Open wide. All right, now bite down. And, through your nose, just breathe through your nose.
We've all been there, right? So those are the moments I usually leave my room as fast as possible because I don't want to see what's coming up next. What if we had an alternative? What if we had a different option for our patients' comfort as well as ours, something that was a little quicker and a little more efficient? And that's where today's modern technology comes into play. We've all had, luckily, at least exposure to digital scanning and digital impressions throughout the past couple of years. And in effect, we are being almost inundated with it. Which scanner are we going to use? How are we going to use it? And how is it going to get integrated into our office? And the amazing thing about that is, with all the time that's gone by, it's become easier to integrate. And we look at the ways this can be better for us. And in fact, if you look at it, it's way more efficient. Even for a new beginner, it's better in your hands to digitally impress when you're starting than it is conventional VPS impressions. In fact, if it takes you 3 to 4 minutes to scan an entire upper and lower arch, as well as a bite registration, that in many cases is up to 2 to 3 times more faster than conventional impressions. It is more accurate than conventional impressions. You don't have and run the risk of distortion in those impressions. You don't run the risk of having to ship it outbound in different temperatures and different climates. And it is easily and quickly correctable. And what I mean by that is you can analyze it right on the spot. So you can take a good look at your impression digitally. You can blow it up on the scanner, and Angela is going to show you that later. So if there's something you just need to go ahead and correct, you just have to pick up your scanner, go ahead and re-image that area or add to it to make sure you've got all the information needed that your lab can use to make an incredible restoration. Unlike traditional impressions, where no matter what we do, the only answer in many cases for accuracy if something isn't right is we have to retake the impression, putting our patient through that same procedure again, and running the risk of wasting a couple more minutes. The best thing I like about this is it's so easy to delegate to our staff. My staff picked this up in no time. And in fact, I do little to none of my own scanning except for the final preparation scan. So everything when I walk into the office is already and scanned. And the only thing I'm going to have to scan after preparation is that final prep so we can get a good model to send off to the staff. Patient acceptance on this is incredible. There are many times when the patient will be done with this, they'll get up and they'll actually ask, well, when am I going to have my impression in? And when they hear that the answer is you already have, and they didn't have to gag or choke their way through it, they're just thrilled with it. And it does become a really nice practice builder when we're dealing with patient acceptance like this. And obviously all of our practices grow based on the happiness and the accepting nature of our patients when it comes to new procedures. This scanning and digital impressions can be used for almost every restorative procedure. Anything restorative that's direct, inlays, onlays, crowns, bridges. We're getting so close to being able to just completely intraorally scan soft tissue that dentures and partials are going to be right around the corner. So when you think about scanning technology and digital impressions, it is really not a matter of if this will be in your practice, but it's just a matter of when. So all of us are going to have to really be able to be open-minded and think about how amazing this is going to be as we restore everything we want to do in our mouths. I'm going to go ahead now and I'm going to turn this over to Angie, and she's going to walk you through all of the procedures. So take it away, Angie.
All right. Thank you, Dr. Giuliani. So tonight or today, wherever you are and whenever you're watching this, just really, want to focus on the simplicity. I think that, sometimes there's a fear factor in incorporating digital dentistry into your practice. And it's just simply, not true. This is a very, very easy, accurate way to offer, better patient care. And so that's what I'd love to show you tonight with VivaScan. So I'm just going to go ahead and launch the software. Now with VivaScan, it's so easy that you can actually, within an hour of having it delivered to your practice, you can be up and scanning your patients. There's online learning modules. They also have a customer success program to make sure that there's someone like a clinical concierge that's working with you that first month that you're incorporating this into your practice. So you can see the software is very basic. We can either start a new patient or open an existing. So for those patients that have already had restorative care, we'll go ahead and pick an existing patient and start a new case. So with this new case, the demonstration tonight, I've got a upper prep. The lower is going to be in my opposing, and the prep happens to be on the left-hand side. So we're ready to now move on to the scan tab. Now, once I'm in the scan tab, I'll go ahead and actually plug in the VivaScan. So the VivaScan has activated tips, meaning I'm able to scan without any fogging. It actually does come with 2 different size tips as well, which is really nice. So you have a standard tip, which you're going to use most frequently, and then a small tip. And I want you to think about the small tip for that limited opening patient. So something to take into consideration when you're looking at incorporating an intraoral scanner into your practice is, the size of the tips. The tips are also autoclavable. With VivaScan, they're up to 300 uses per tip, and it comes with 3. So that's 900 patient scans before you would have to purchase an additional tip. Now, in this lower left-hand corner, you see if I left click on the tip, that's going to be able to capture the information. So how long I've been using the tip, how many times it actually has been autoclaved, which is really nice for the clinical team to be able to track the usage of those tips. VivaScan also acts as an HD camera. So when you pick up VivaScan, I don't want you to think of it just only for restorative solutions, but like Dr. Giuliani mentioned, think about it from a diagnostic solution as well. So in the hygiene operatory, when that new patient presents themselves in your practice, being able to scan their upper, lower, take HD snapshots, what that does is it really draws emotion into the patient. So the patient's now seeing their mouth up on the screen, that leaky amalgam or that crack in the tooth, and really takes ownership for what they're seeing because you were able to scan and take those photos right there with the patient in the chair with VivaScan. So you can see the tip is now activated. It is green, which means we're ready to go. Tonight I'm scanning a model, so I'm going to put it on model mode. But how model mode translates into the mouth is actually if you have anything that's highly reflective. So think anything metal, your gold crown, the PFM, maybe a really shiny, polished up amalgam. You can always put it on model mode to help with reflectivity. So everything in dentistry is free up and wait. So we're going to pretend that we're waiting for our patient to get numb and we're waiting for Dr. Giuliani to finish the preparation. So as a team member, I'm going to go ahead and scan in the lower. So I'm using right now the bottom button on the VivaScan. So using the VivaScan is more of like a remote control to try to mitigate that risk of moving from, cross-contamination from the mouth to the mouse or to the laptop. So what you're going to see on the right-hand side of the screen is going to be our live view. And then in the middle of the screen, you're going to be seeing the model build. You will also hear an audible tone, which is letting me know as a clinician that I'm actively scanning. You'll also see a green box. The green box is letting me know that I'm nice, proper focal distance. If I start to hover away, it'll change colors. Again, now that's just a visual aid for me. So we've got visual and audible options for us while we're scanning. So I'm gonna go ahead and press the top button on the scanner and we'll start scanning in the quadrant. So getting the teeth nice and centered, scanning towards the mesial and then rolling into that lingual vestibule. Coming around and now capturing the buccal. So VivaScan actually likes aligns the bite by capturing 2 to 3 millimeters of gingival tissue. Now, if I accidentally scanned in, let's say the tongue, or in this instance, my finger, we also have an automatic AI feature, which is called active delete. So I just simply press the bottom button on the scanner and you'll see that it's now eating away, or I call Pac-Manning, that data. So it's not going to remove it all at this very moment, but as soon as I generate the model, you'll notice that that information is going to now disappear. So that's a really nice way for us to make sure to keep out the lip, the cheek, the tongue, the finger that might get into the scan. And we're ready to now move on to the upper. But you'll see right here that that information, the finger that I'd scanned in has been removed because of this feature right here, active delete. So we'll move on to the prep scan. And these are actually Dr. Giuliani preps. So we'll actually be scanning that in, scanning in the upper. So same thing. So scanning towards the mesial, rolling into the lingual. So most scanners but work best when you use a scan pattern. So trying to stick to that is for efficiency as well as accuracy. Now just doing some rotations here, we're going to fill in those interproximal contact spaces. So as long as I can see it on the live view, then I know that I'm capturing that information. We'll just focus on tooth number 11 today. And now if I just simply pause over tooth number 11, then the scanner is going to take an HD photo. So you could hear that shutter. Now that HD photo is going to be automatically uploaded to the actual send tab. So now I'm using the VivaScan again as a remote control. So it's going to generate the model. That HD photo, like I mentioned, is automatically uploaded up here in the upper right under images. And it's really nice. The labs enjoy that, receiving the HD photo, because now they have something to look at. If there's any discrepancy, maybe where the margin is in contrast to the gingival tissue, equigingival preps are actually the most difficult to see. So VivaScan also acts as a shade assist. You'll notice that the shades are showing up. It's better in the mouth than on the typodont. But we'll go ahead and now identify that we've captured 100% of the information that's needed, which is, of course, the preparation, as well as then that interproximal contact space. So if I had this dark blue color here, that was actually where the floss was going to snap, or on the preparation itself, I would simply just turn the scanner back on and go back into the mouth to capture the additional information. Luckily, though, with digital dentistry, less is more. And because this little piece right here on the lingual is not going to affect the fit of my restoration in tooth number 11, we're actually finished. There's nothing else that I need to do here. I've captured that 2 to 3 millimeters of gingival tissue. I've captured everything for my prep, and we're ready to move on to the bite. Now the bite, with VivaScan, we're going to do more of a serpentine scan pattern. So like I mentioned, it uses the gingival tissue, and you're going to hear an audible tone and see data fly into place. So the scanner is going to automatically then align, like it just did there, align the data, and there's the upper. So you kind of heard the 2 clicks. So in 15 seconds, we've got the bite. We can now generate this model, and that's it. So you're seeing in a few moments here, we've given a better patient experience. We've been more efficient and certainly more accurate, down to microns, within 30 microns accuracy. What I want to show you next before we move on and send this to the lab is our prep clearance heat map. So another feature within the software that's highly beneficial to us as clinicians is being able to identify, have I reduced properly for the material prescribed? So now, instead of it showing shade, if you'll see if I just slightly hover over the occlusal, I'm able to see the clearance. So as long as I'm, prescribing, if I'm prescribing Emax here, I know I need at least 1 millimeter of occlusal clearance. If I didn't have that at that moment, I would simply come to the eraser feature, erase this spot that was possibly under reduced, and then you would make the adjustment as the clinician in the mouth, and then I would simply scan that back in. So no second impressions. But we are ready to go here and move on to the Mark tab. So within the Mark tab, this is where you begin your virtual lab script. So I want you to think virtual lab script. I'm either going to just simply mark the tooth, or I'm going to, if necessary, mark the margin. But when you're taking that HD photo, it's really not necessary. You're able to just simply mark the tooth, let the software know if it's going to be a full coverage crown or if it's going to be a partial coverage crown, the shade, as well as the material.
And obviously, you guys, it's funny if you take a look, what Angie showed you is for a simple single unit restoration, you just honestly only took a digital impression of half of the arch, correct, Angie? And even talking your way through that, both upper and lower, as well as the occlusal bite registration, what did that honestly take you? Maybe a minute and a half?
Oh, if that, right. And, I'm talking about different features and hey, we might have to show that this is going to be sent to the lab here. And I mean, that's really the gist of the software. All I was going to do was simply mark the tooth and then click on the send tab to send it to whichever laboratory of your choice. So what Ivoclar uses is called their Ivoclar Cloud. It is the HIPAA compliant communication platform that allows us to utilize any laboratory that accepts digital files. So your STL file, your PLY file, which is the color file. They simply just register their laboratory with an email address, and they can send and receive as many cases. So that's all included. That's something that Ivoclar has done very, very well, is just decided that they're going to have a, one package deal. So, no, I call it WTF, what the fees, there are none with Ivoclar. So it's just, that one price point in, which is really nice. I think that's something that, also has clinicians shy away from the software or incorporating digital dentistry are all the fees, the annual fees for the software. But I think right now, Dave, it looks like here we go.
Just about the time you're about to give in. Huh?
I was just about going to give up on this one. And we'll just open that case back up.
Well, and I can't speak enough, Angie, while you're doing that, though, everybody, I guess this is a good point to really honestly at this point highlight the fact that you're there, right, Angie? Because not every company has a customer service advocate. So if this were to happen to me online, or this were to happen to you online with Ivoclar, you would literally be calling Angie for this. So it's kind of a funny situation that it did happen, because you have no one to call, Angie, but at least we all have you, right?
Well, thank you. I appreciate you saying that. Yeah, they call me AAA. Angela's always available. So, all right. So here we go. Tooth number 11. But you're right, no sweat. It's one of those things, like these things happen. And so when you do have that clinical concierge right at your, literal fingertips, just shoot me a text and I can quick live log in. And I can actually take over your screen, your mouse, I can see everything. So this is what we just did, is filled out the lab script for tooth number 11. And now I'm ready to just move on to the send tab. So now in the send tab, again, you're able to have as many laboratories as you want in there. And I think I'm just moving too quickly, I guess, for the software tonight. It's just not wanting to move along with it.
I think the funniest thing too on this, Angie, is that your patient is already, so if this were to happen in real life, your day in your appointment still moves on with that patient. You've captured all the data. You've continued on with the temporization of the restoration. You've got your shade. The patient can truly leave. So none of this disrupts anything about your appointment or your schedule for the day. Unlike some of the in-office, milling that I've done for 20 years, if you were doing this in line and you were in the office and you had to send this to your milling chamber and you're waiting on this type of a glitch actually does back up your day. So I think a lot of people are using scanners. The way I think it's evolving is the scan and send. So you actually have the ability, if there's a technology glitch, it literally doesn't affect your patients or you for the day. And you can manage this by calling support in this case, you, and then having it all taken care of.
Now that is a very, very good point. I appreciate you bringing that up. I just want to show here before I hand it back over to you that HD photo that we took is here the laboratory can now see the stump shade. They can see the separation between the enamel shoulder and the gingival tissue in case there was any discrepancy. Both the STL and PLY file will be sent. So again, the PLY file is the color file, which is what you're seeing as the clinician. The STL is what they're going to pull into their lab software to mark the margin and design the restoration. We just simply need to ask for the crown back in 2 to 3 days instead of 2 to 3 weeks. And we do not need to send it anonymously because, again, Ivoclar uses their cloud, which is their HIPAA-compliant communication platform to the lab, which is unlimited send and receiving. So we're just going to click on send. And within 1 minute, just depending on the size of the case and your upload speed, this is going to be sent to the lab. So I think that's what we've got. That's the simple scan and send solution that Ivoclar has to offer. And I think we've got some more information that you want to share, Dave.
Yeah, so we're gonna keep moving forward, but thank you very much, Angie. And I think that one of the things that's best about this is that it gives you the ability to truly see, even with this type of a small little glitch, how quickly we can move on and how it doesn't affect your day-to-day operations. And I really love that about today's technology, that even minor little glitches that we all are used to in our technology really, in most cases, especially digital impressioning, don't affect your patients, and they still leave having a great experience here. And I think that's one of the nicest things about it. What we're going to do, though, is we're going to move forward. Now we have to talk about what can you do with this and what kind of are the values to your practice. And everybody wants to know, in many cases, what the limitations are. Well, when it comes to basic restorative materials, you really can order anything. And that last, in that one screen where we talked about traditional dentistry, there was a gold crown or a PFM on there. And of course you can do that. As Angela said earlier, we're basically just sending out an STL file to the lab. So it's no different than sending a basic impression out to the lab where you can get any restorative material you want back for your final crown, inlay, onlay. But a lot of people today are thinking that, what can I do with this outside of just simple crown and bridge? And the majority of what we do as general dentists are literally indirect restorative procedures, inlays, onlays, crown and bridge. And this is what makes up the majority of my use of my scanner. But at the same time, I will always think about occlusal guard scanning. And when you think about how accurate, Angie said, down to the 30 microns, you can get occlusal guards that fit amazing. Simple vacuform type retainers or clear retainers, Holly retainers. You can get, once you have all the teeth and you can get the soft palate or the palate scanned, you can send out for any type of restorative or orthodontic appliance you would like. So we're going to move forward a little bit and talk about some of the materials out there, because glass is now becoming the most accepted and modern material we have. So we have the basic glass ceramics that we all grew up with, the feldspathic porcelains, which have been around since the 80s, which were kind of replaced a little bit by the lucite or the more translucent porcelains like Empress. When that came out in the 90s, we were all looking for glass that was not only going to function well, but also have some strength and look as natural as possible and transmit light through it, because it was a very translucent material. So we're going to talk about where we're going to use these in just a second, but we can also do some of our high strength ceramics and our modern dentistry. So these two, between the glass ceramics and the high strength ceramics, are what we think about when we think crown and bridge every day. Our lithium disilicates are our EMAX, and then our zirconiums. Those are, of course, the two most common posterior restorations that are delivered by us now as dentists, overtaking gold by far, and obviously PFMs. But what we forget a lot about is some of the composites and the temporary materials for certain situations that we're going to look at that are available to us just by taking a simple digital impression. So if we take a look at the mouth, the things we want to kind of think about is where we need some of the materials that we're talking about tonight. Obviously, in the anterior area, whether it's maxillary mandibular, aesthetics are such a huge concern. So we want something that's not only going to function well with good strength and stability, but we want it to look nice, versus the posterior, where it's always got to be as strong as possible. And what we're looking at in a situation like that is we need strength, we need durability, and we need something that's going to function well in a typical day-to-day occlusal load. So we're always looking at high strength, but the beauty of today's materials you're going to see is that we can not only get strength, we can also get aesthetics for all areas of the mouth. Now the premolars there are in green, and that's because we're looking at, depending on your patient, you really have the choice with today's materials to go all the way to an EMAX type of a crown where you get aesthetics and strength, or you can go with something like a Empress type of crown where you get a great deal of aesthetics, but you also get strength in a patient that can, use a simple lucite porcelain there without the need for the durability of an EMAX based on their occlusal load. So the premolar area and the bicuspids are really just an area, including the anteriors in certain cases, that depending on patient function and load, you're going to select your materials accordingly. And I'm going to show you some examples of both. We're going to give you a quick history with some of the glass ceramics that we talked about. The Empress materials were kind of brought to life by our labs in a pressable form in the late 90s. And what this did for us is it gave us a really nice fine particle glass ceramic with enamel-like wear. When we deliver these and when we try them on, what we were looking for is the feldspathic porcelains that it replaced were very much larger particle porcelains, and it ended up in many cases, in certain, as we've all seen, anterior situations, a lot of opposing dentition wear. Once the Empress and these lucite porcelains were introduced into the market, they really were able to function like traditional enamel in many of our situations where we placed them in the front of the mouth. So we didn't have to worry about the opposing dentition wear like we saw with old PFMs that had feldspathic porcelain on them, or some of our 100% monolithic feldspathic porcelains and ceramics. These have to be etched, and they've got to be adhesively bonded for strength and support. We can't really conventionally cement these, and we're going to go over cementation in a little bit, but what our goal is to get some increased strength through our bond to really bring the material to its fullest strength under function and load. We can use these for inlays, onlays, veneers, or crowns in the anterior or bicuspid area of the mouth. And what we get out of these, though, you're going to see is an amazing blend into the tooth. Mostly in today's world, we're seeing them in anterior use where aesthetics are a high concern, in full crown or veneer situations, because as we see and as we move forward, you're going to see a bunch of examples where we have better materials as everything's evolved in dental materials. We have better materials for inlays and onlays, and we're going to show you some examples of those. When we take a look at certain cases, what we want to see and what you do see is a typical case, right? These walk through our office every day, and this is a patient who was unhappy with her 2 central incisors. Obviously, there are other concerns there that we can address with a full mouth reconstruction, or at least an anterior reconstruction like we did here. The position of tooth number 7 and 10, the difference in colors, obviously, from the 2 centrals to the rest of the dentition. But really, the occlusal problem at the lateral incisors from the maxillary to the mandibular arch are going to cause some sort of a interference or a functional discrepancy if we don't treat this well. So what we did for this patient is we took Empress and we just did an anterior reconstruction. And by prepping the teeth, you can see 6 months out how nice and healthy the tissue is, but also how we were able to correct the occlusal discrepancies, add some length to the lateral incisors and the canines, really lock this patient into a better class 1 after they've whitened, blend those anterior 6 units in, and protect the incisal edges of the lower anterior teeth as well as the maxillary anterior teeth, and keep everything symmetrical, really abiding by the golden proportions, keeping everything across the arch really nice, and really minimizing the traumatic effect of an older technology anterior reconstruction by giving in a material for this patient that's going to wear very much like enamel to protect those lower teeth. So this is simple lab ordered Empress porcelain, and you can see how nicely the tissue really does respond to it and how healthy everything looks long-term versus the picture in the past. When we take a look at other simple situations, this is a basic thing we see every day, and one of the hardest things we have to face every day in dentistry. So there's nothing worse than a patient coming to us where they're unhappy with either 1 or 2 of their anteriors. And obviously, this is a case that we can only improve on because it would be hard to not make an improvement there. But these are 2 old veneers where there had been some recession along the gingival crest. But over time, as the patient went through ortho and whitened her teeth, the obvious shade defects and the lack of translucency with some of those old feldspathic porcelains is evident. So our goal was to literally take these off, re-prep these teeth so the margin and the finish line were right at the gingival crest, and then go ahead and match up with Empress porcelain those 2 canine and lateral to the remaining dentition. And you can see the beauty of this material looks so much more lifelike than the old feldspathic porcelains, because being a little bit more translucent, as the lucite porcelains are, you're going to see more of the natural color of the tooth come through, and that's going to give it a better, more natural look. And in this case, obviously, you would never know that those were 2 crowns versus the natural dentition for the patient. So this material, whenever I'm thinking aesthetics in the anterior, is the first thing that comes to mind, and Empress has never let me down in any form at all, from the lab or in a chairside version. When we start thinking about the posteriors and some of the high strength ceramics, 2 things come to mind when we're speaking full ceramic coverage, and that is going to be either lithium disilicate or Emax, or zirconia. So the invention of these and the introduction of these into the dental market has really changed the way we look at posterior reconstruction, because not only do we now get to think about function and occlusal load and structural integrity of the restoration, but we now have ways to make these at least full coverage restorations look a lot more aesthetic, because we can give them not only a natural all ceramic look, but without having any metal for the substructure, we're really allowing, in many cases, the natural dentition, because of the multiple translucency options, we're allowing the natural dentition to really come through in these. Both of these have been around, obviously, Emax since 2005 and zirconia in 2015 for a little while in our world. And we're seeing that the beauty of both of them is they can be bonded or they can be cemented. So we have the ability to use an adhesive or a self-adhesive cement with either of these. And we have the ability, depending on what our clinical situation is, to choose to conventionally cement them. Obviously, they can be used in any way we would use any type of ceramic restoration in onlays, crowns, and veneers, but mostly now these are being used for our posterior full coverage. The great thing about Emax is that you're getting 500 plus megapascals of biaxial flexural strength, and it allows us really to start thinking about how we can restore somebody with all ceramic, even in really deep posterior regions, meaning first molars and second molars. I personally have 4 Emax crowns on my second molars, and I've never had a problem with them. And throughout the years, when prepped correctly, which we're going to go over in a second, and bonded in, depending on what our thickness is and what our prep guidelines are, we're going to get, honestly, a restoration that not only looks great, but can function really well in the posterior region of the mouth, all the way back to the second molars. Indications, as we talked about, you can be very minimally invasive with these, down to 1 millimeter. And I'm going to talk about that as we talk about prep guidelines in a second, but minimally invasive, you can go down, as I just said, to 1 millimeter, but it just has to be bonded. For single unit crowns, 3 unit bridges, implant supported hybrids, abutments and crowns, you can use these for veneers, and obviously inlays, onlays, or partial crowns if function dictates the need for that type of strength. When we talk about prep guidelines, it allows us to be a little bit more, I guess, choosy when it comes to what type of reduction we want. So sometimes in the second molars, we don't have the ability to reduce 1.5 millimeters like some of our porcelains require. So if that's the case, we can go down, as we just said, to a minimal reduction of 1 millimeter, 1 millimeter at our occlusal, 1 millimeter at our axial. And as long as we are adhesively cementing these, and we'll talk about that in a minute, we have the ability to be very conservative with what we're doing. In some other situations where we have the room to occlusally reduce our preparation down to 1.5 millimeters, and we can get some axial reduction in that 1 to 1.5 millimeters, it allows us, the strength of this material allows us to conventionally cement them. And we'll go over some cement suggestions in a little bit, but really now we have the ability to make the choice based on our clinical situation that we're sitting at, and really provide what is going to be the best restoration for our patients through the preparations and the function that they require. Here's a couple examples. Now, if you take a look at tooth number 7, this patient was not wearing his partial. So when it came time to restore his lateral incisor for a wedding, so this patient walks through the office and tells me he's got a wedding coming up for his grandson in the next 2 weeks. Well, he wasn't wearing his partial, doesn't like it. So we knew, based on that edge to edge, that we're going to have to put something strong, and some of the more conventional porcelains like Empress weren't going to work. So we were able to send in some photos, get some pictures and some stains, match up the shade really well. He wouldn't let me do that crown on tooth number 6, but he did let me fix it up with a composite. And you can see how nice it was and how easy it was to match tooth number 7 to his natural dentition right here. I chose Emax in this case just because we needed strength and durability, because there's just a lack of posterior occlusion. That's an example of a single unit, but what about a full unit case? And when you take a look at this patient, this was a full unit, heavy wear patient, full mouth heavy wear patient. Patient had just gone through orthodontics, and you can see the amount of wear based on malposition and orthodontic needs that this patient was getting. Because of that, we had to choose a material that was going to give us not only our functional strength back, but also our aesthetics. And that includes the length of the teeth. Now, if you look at her in the lower left there, you would never guess that she's actually only 36 years old. She'd come from Europe and she wasn't really exposed early on to good dental care, but we were able to, with Emax, completely restore her upper and her lower dentition into not only a functional, but an aesthetic relationship that's going to function with her and look good for years and years to come. So I chose Emax in this case rather than maybe posterior Emax and an anterior Empress, because I knew, based on what I saw in her pre-op situation, that she was going to need strength and durability. We obviously put her in a splint, but I routinely will choose Emax when I need function and strength as well as aesthetics over any other material, because it does really well in all areas of the mouth. That brings us always to zirconium, because people always get very confused and concerned about super deep posterior, meaning the second molar area where they just feel that they need more strength. The great thing about zirconium, and I'm going to show you a couple cases in a second, is that it is very, very strong. So when you order these from the lab, you're getting some good aesthetics with it, not as good as the traditional ceramics like Emax, but you're getting very good flexural and fracture toughness strength, up to almost double, so almost 1200 megapascals. And it really allows us to get conservative, as you can see here, where we can go down to almost 0.6 millimeters of reduction only in the posterior and 0.4 millimeters of anterior reduction. So it really allows the fabrication of restorations with really, really thin walls where we need them, especially as we all think in the second molar region. I don't know if I would ever use this material in an anterior reconstruction, but really it does serve me well if there's a deep posterior bite in the second molars and I really need to be as thin as possible because we're worried about pulpal exposure. When we take a look at these, though, this is a great case I just recently did. And if you take a look at the difference, you can see the pre-op photo on your left. The patient had 2 old PFMs, wanted those replaced. And you can take a look. I ended up replacing tooth number 31 with zirconium and tooth number 30 with Emax. And you can actually see the difference in the aesthetics, where the zirconia crown looks a little bit more like opalescent and pearl-like compared to the natural blending in shade and translucency of number 30 when you compare it to tooth number 29. It really seems to flow and blend in really well. I will tell you, one of my favorite things about Emax is if you take a look at it, it's just the radiolucency of it. When you look at the lower radiograph there on the right-hand side, we have set ourselves backwards with zirconium 20 years in diagnostics. I would always, when I can, place a radiolucent restoration on there so I can see what's going on under those preps, and you can see how nicely the fit is to the tooth, and you can actually see that you've got a good cement seal everywhere, whereas zirconia blocks off, just like traditional gold did, all of our diagnostic capabilities when it comes to tooth number 31 or any tooth we place that on. I believe in zirconia when it's needed, but I probably use this as a restoration maybe 5% of the time, because I really do believe in Emax and the ability for it to withstand most function and strength issues. The great thing about this, though, is that we have choices now. We can use all ceramics in every area of the mouth. Lithium disilicates or zirconia in the posterior. And if we need to, just for sheer aesthetics and we don't need the strength and the fracture resistance, we can go right into Empress and really know we're getting good when bonded aesthetics that are going to, service the patient really well. And these materials, as I said, can be mixed with Empress in the anterior and zirconia in the posterior. The great thing about digital impressioning, though, is it allows us to use any material. There are composite blocks. So now when I do composites in a quadrant situation, where if I'm going to send something out to the lab, where let's just say I have a bicuspid that needs a two surface restoration and a crown on the molar, I'll go ahead and do an inlay if I'm sending it out to the lab on my bicuspid, and I'll do a full crown on the molar that needs full coverage. Or in certain cases, if we just want to do inlays where we're right on the border, does it really need a crown? Can we get away with being a little bit more conservative and just do an internal restoration versus a full coverage? So the great thing about this is it's basically composite. So we're actually restoring the tooth with composite material, and we're bonding in, which gives it the elastomeric movement with the tooth, and it's going to give it function, and maybe, if we can, put off the crown for a little bit longer for the patient's well-being and safety. So if you take a look, this is a simple thing. Obviously, it's simple two-surface composite. We want to maintain the marginal ridges, the anatomy, the emergence profile, and the embrasure spaces in a simple composite inlay can do that. And you can see all the way on the right how nice that turned out. This is my favorite place to use them. Obviously, in bigger cases where you've got that nice buccal cusp, you've got a good distal ridge, and would we want to cut that out of there and reduce that entire tooth in a second molar, running the risk of fracture in certain cases, or would rather use the buccal cusp and the lingual cusp for support and get an internal restoration like this tetric inlay. And you can see how nicely the transition from the occlusal surface to the marginal ridge looks, keeping our embrasure spaces so nice, but at the same time controlling the emergence profile and the contact way better than we could if we placed a direct place composite, which would not have been easy to maintain that contact in those contours with. One of my favorite things to do with it is a case like this, where you can see the patient had a kind of a submerged 28. They had a large composite on tooth number 29, and we needed to restore exactly what I said, the emergence profile and the embrasure space between these two teeth, because it really was an unhealthy situation. You can see how the tissue was impinged upon from 29 in the mesial, and by simply doing an Emax crown and a tetric inlay in that case from the lab, we were able to get a more hygienic situation and allow the patient to keep it a lot cleaner, while at the same time getting really good function for this patient. TelioCAD is a great material for us for temporary uses. If we have to put somebody in a long-term bridge, it's just a material you can send in the impression, put somebody, you can scan it, send it in, the lab will make you a telio or a PMMA block that'll give the patient up to 12 months of function and occlusal stability. But where I like it the most is in anterior situations where you can actually do an implant and intermediate temporization of this. And you can see right here, patient had a fracture of tooth number 8. We were able to extract it. We were able to go ahead and order by scanning it from the lab. We ordered the guide. They gave us the implant. We were able to have the temporary made ahead of time. When the patient came in for the extraction, we were able to place this temporary. And kind of a funny story, the temporary looked so good, the patient never came back for the final restoration to this point. So sometimes making them a little too nice might hurt the individual financial progress of the patient, but or of the practice. But in this case, the patient was happy and she could function in this situation without having to worry about a flipper or an Essex retainer to solve that problem. So many opportunities with the materials available at the lab. Then it brings us to what do we do with these materials when we get them, right? Cementation and bonding is one of the hardest things and the most, I guess, let's say, anxiety producing parts of my practice every day. And that's because most of us are used to conventional cement and the ease of it, the squirt and go, or the just mix and put in the crown and put it on without having to adhesively bond. But what we have to think about is how do we want to deliver our restorations? And this is the easiest way to think about it. Conventional bonding or conventional cementation just basically holds the space. It fills a space, and it really is dependent on the geometry of our preparation. So if you've got a nice, good retentive preparation, you can, in many cases, depending on the material, Emax or zirconia, get away with a nice conventional cement. And we're going to go over those in a second. But if you've got some limitations to the amount of reduction that you've had, or the prep geometry based on decay or wear, we're going to need something a little stronger. And that's where we count on our adhesive cements to really make us a little bit better and get that retention we're looking for through bonding. There are 3 basic categories of cement. There's the adhesive cements, there's the self-adhesive cements, and there's the conventional cements. And as you can see on the side, on the right side of this triangle, there are many, many options for all of us to choose from, some of them from different companies, but all of them very much apparent to us. And I'm sure there's not a cement on this list that most of us don't use in our office and in our operatories. The great thing about this, though, is Ivoclar does provide, and I really believe in this. I believe in sticking to one company in one line of products, because just like they've got Angie to help you out if there's a need for any of your technology issues, it's always nice to know that all of our products are designed to work together with Ivoclar. These are designed for the success, not only of the restoration, but for the patient's comfort too. So the one thing I really do appreciate from Ivoclar is that in every category of these cements, you've got a cement that's available. So if you want to conventionally cement your zirconium, you can actually use Zircad or SpeedSem in this case. And if you want to adhesively bond your Emax, you're going to use your Variolink aesthetic or your multi-link. The nice thing about these is, depending on your prep and your clinical situation, both of those restorations allow you the ability to adhesively bond them or conventionally cement. So let's take a look at these really quick. One of my favorite cements, and it used to be Variolink veneer, and it got a little complicated based on all the different shades, but when this got converted to Variolink aesthetic, it gave us the ability to have an aesthetic adhesive cement system that gives us a couple different shades for stability and permanent cementation of all of our all ceramic restorations. It's available in a couple different options, a fully light cured version for anterior restorations like veneers, and a dual cure for most of your posterior needs, crowns, inlays, onlays. So I use the light cure model pretty much for all of my veneer situations, and I use the dual cure for all of my full coverage. It gives you full control and time, as well as cleanup ability, and something really nice to not worry about having any cement caught in between the interproximal areas. When you take a look at the aesthetics, it has an amazing shade system. There's only 5 shades, which is nice. You've got your neutral, your light, and your warm, and then you've got your light plus and your warm plus. I will tell you, I rarely count on my cements to change my shades, meaning I don't like to correct my shades through cements. So I stick to mostly neutral, but where you need a warmer one based on the color of the tooth, or a lighter one based on the same shade, you have the options here to do this. And the great thing about it is you can gradually brighten or darken if you need to, and you're not relying on just the cement to change the shades. The stability of this is nice because in many cases where we've seen past cases where you've cemented them, the patient comes back 6 months later and they talk about how gray their restorations look. Well, we all know the porcelain doesn't change shades. It's the fact that our cements over time break down, and the amines in those cause color changes. And that's what I love most about the aesthetics of Variolink aesthetic, is that it's 100% amine free, which means it's not going to gray over time. And the light and photo initiators in it are going to allow you to really expect no visible shade changes in exposure to light or in obviously a human environment like the oral cavity. SpeedSem Plus is a more self-adhesive product. And the great thing about this is it offers us a combination of performance and user friendliness. So it gives us that squirt and go almost confidence without having to worry about the anxiety. So if your prep geometry allows you with a very retentive prep to really not have to rely on our adhesive cements to hold this restoration on, you now have the ability to choose this to use with all zirconia, metal, ceramics, or even for our lithium disilicates. You can permanently cement this on natural teeth as long as there's good retention, like we talked about, to the zirconias, metals, Emaxes, and endo posts even in certain cases. So I use my SpeedSem in any situation where I'm not going to directly use adhesives on it. So again, amazing. You can even use it on implant abutments and depending on the material, metals, ceramics, and lithium disilicates. So you can use it not only on natural teeth, but on some of our implant solutions also. The way this works and how the self-adhesive side of it works is that it uses an adhesive monomer called MDP, which consists of a bunch of methacrylate phosphoric acid groups, which allows the tooth then to bond, or allows the cement to bond to either the tooth structure on one side of the restoration, but also the metal or the glass structure on the other. So it really forms that amazing link between your restoration and your tooth. So you don't need any additional adhesives or bonding agents with it. Literally, this can be a squirt and go type of cement with easy cleanup. So it's one of the best things that I go to first whenever I don't need to traditionally use adhesive cements. The one thing about it is it does come in 3 shades, which are really nice. It comes in an opaque, a yellow, and a transparent. Most of the time, transparent is all I have to use. It does, because of the NDP, have to be refrigerated overnight. You can take it out in the morning and leave it out all day, but at night it needs to be put back in the refrigerator. So those MDP and those methacrylates can be stored properly. Very nice, easy to use, and it really is my go-to cement when I'm not going to adhesively bond something in the mouth. Recently, Ivoclar released Zircad cement. The great thing about this is it really is an economical, easy way to use in place our zirconia restorations, designed for good retentive, high strength, and our zirconia-based restorations. Super easy to use. You don't need any adhesive or bonding add-ons with it. And you can basically, once you try in your zirconia crown, you can use an IvoClean to clean that up, and then go ahead, since these come etched from the lab, use your IvoClean and then literally just place this in the crown, and it will bond nicely to tooth and to the zirconia crown. The great thing about it is the flow is nice and controlled. You can actually tack cure it, which is really nice. And it allows the excess material to quickly be removed, and it allows the material to go on and continue its set underneath the crown. So gives me the 3 options when I need it. And the best part of this is, like a lot of our modern cements, it does release fluoride. So that helps, give us some peace of mind into, preventing future caries and recurrent decay, as well as it allows us to, have all the easiness that we're talking about in cleanup, as well as the economics that some of the more adhesive cements in certain cases don't give us. When you're looking at the cost, this is quite possibly the nicest comparative cement on the market, which gives us all of our fluoride release and an economical way to deliver our zirconia crowns. We're going to wrap this up with just a few questions. I know that was a lot of information, and we're going to kind of bring Angie back on and talk about any questions you guys might have on anything from scanning all the way to cement. So we appreciate the time tonight, and we'll hang out here for a few more questions.
Thank you, Dr. Giuliani. I was also answering some of the Q&A while you were presenting.
Oh, nice. Okay, so you've taken it off, and look at that. I even finished up on time, so we
can go ahead
and answer questions. And that was even after our technology. That was even after the technology issue. So
yeah.
See how fast I can speak.
The question, one of the questions was, where can they have training? And so, just please know that we've got all of the local Ivoclar representatives do have their own VivaScan system. So if you'd like a demo, you're absolutely able to work with your local Ivoclar representative. If you don't know who that person is, you can simply just Google local Ivoclar representative and type in your zip code and be able to pull them up. There was also a question about scanner, if it could be used offline. And the answer is yes. You do not need the internet to use the scanner, but you would need to have the internet, the Wi-Fi ability to send the case to the laboratory.
And you know what, I can't speak to that enough. I mean, Angie, as you know, Wi-Fi in most of our offices can be sometimes sketchy. So the beauty of that, if the Wi-Fi goes down, you can still continue on with your procedure and send the case out to the lab as soon as your Wi-Fi comes back and up and is a little bit more predictable. So I think that's one of the best things about the system. It doesn't use the software that is internet-based. The software is all downloaded and right on your scanner, so you don't need to worry about the internet to go ahead and complete a case in any of these situations with the VivaScan, which I think is honestly one of the best features of it.
Yeah, another question was, so I'm a huge fan of PVS impressions, but often, with the deep prep, I need to do more of a gold crown, feather edge, maybe even a no margin. Can the scanners pick up the definition needed? My response was, that every scanner has certain millimeters in depth, right? VivaScan is 15 millimeters, but it really comes down to tissue is the issue, right? So proper tissue management, there's no scanner on the market that can see through tissue, pooling blood or saliva. So you'd really have to control the oral environment, make sure that, the scanner can see the margin, as well as just, maybe even marking the margin within the software. So most softwares have the ability for the clinician to mark the software, or to mark the margin rather. That would be important to be able to identify, where the edge of the feather edge margin or no prep margin is, versus tooth morphology for the lab.
Yeah, I can't agree more. You should kind of remember that if you can't see the margin, whether it's a VPS impression or a digital impression, if you can't see it, your lab can't see it. So I 100% agree with Angie on this, is you have to manage your tissue, whether it's digital or analog based. But I will tell you, I've never seen, when the tissue's been handled correctly, depending on the depth, I've never seen something that a scanner can't reach that VPS can. And in fact, I think the scanners today are getting so good with their light and deep sulcuses that I think we're getting a little bit more accurate, even in feather edge margins. Don't you think, Angie? I don't think I've seen a case where, I've ordered gold before and it's been a feather edge margin on a deep distal of like a number 30, and it's been feather edge, and the scanner's been able to capture that sometimes 6 millimeters below the tissue, even in a periodontal condition when the tissue's been managed well.
Yep, agreed. Dave, there's a question: is the best option for veneer for cementation Variolink?
Yes, and I would use the Light Cure, Variolink Aesthetic Light Cure. Check your shades, but neutral for sure. The Light Cure allows you to control it. It's a little less thick, so it allows you to really fully seat that restoration and get it into position and manipulate it enough and slide it around so it locks into its position. Then you control it with the light and attack cure. So Variolink Aesthetic Light Cure is going to be the best one. You wouldn't want the dual cure in a situation like that.
Okay. Well, I think we're right at our time here. If there are additional questions.
I can't see any of them, so I'm going to rely on you for that.
Okay. Well, I think that we are good here. So I want to thank everyone on behalf of myself with Ivoclar Vivadent, and of course, Dr. Giuliani. It's always a pleasure to get to present with you.
Oh, as usual, it's always an experience, Angie, and I enjoy every minute of it. So you guys, thank you so much for joining us tonight. If you have any questions, please feel free to reach me at the email on the screen, and we'd go ahead and happily answer any questions you might have additionally.